Okay, well, we're nearing the end. Just a couple more talks, and certainly I'd like to thank the hosts as well for a really tremendous conference, a great venue, and a beautiful city to visit and to explore. It's been a fabulous few days, so thank you very much. We're going to switch gears a little bit from lung to brain for a moment and try and talk a little bit about some pharmacologic interventions and things that will probably come our way in the next 3 to 5 years, I hope. The brain is still a relatively unexplored area, so we're working on ways to deal with that aside from what you've already heard about in terms of hypothermia. So what I'm going to try and cover in the next 40 minutes or so is to talk about some of the agents that are being used for neuroprotection. No, that's not working. There we go. For neuroprotection, and ones that are potentially on the horizon in terms of being utilized and being shown to be effective in animal studies and may come to clinical trial in the next few years. And others that are more of a potential agents for neuroprotection from the maternal fetal perspective, vulnerability of the developing brain, and a bit of a focus on prevention. So if you think I got beat up because of humidity, this next hour should be really fun. Okay. All right. So this is a common theme in my talks, and I really do try to emphasize the fact that we're really looking at a brain that's rapidly developing, and so it's my belief that sort of a one-shot approach to dealing with brain protection or neuroprotection of the brain is going to be challenging. That we're probably going to have to look at multiple different types of therapies. And multiple approaches to how we're going to protect these little baby brains as, number one, we see an increasing survival of premature infants, and two, this heterogeneity of insults. Right now, most of the therapies have been focusing on rescue. And that really pertains to about, like I said earlier, about 10 to 20% of babies who have a so-called perinatal asphyxial insult. And we rescue them with things like hypothermia and or drugs on top of that. A real big push and change has come in the area of rehabilitation that some of you may know about in terms of looking at kids who have cerebral palsy, particularly things like hemiplegic cerebral palsy, where constraint-induced therapy has made quite a bit of difference and improvement in children's outcome, where people are using transcranial magnetic stimulation to improve gait and or hand usage. And we're doing several studies now using bipedal gait analysis to look at improving overall motor function and movement. And what we're generally finding is that if you enhance either passive or active movement of one or both limbs, you're going to find an increase in their overall ability to recover. And I'm not going to really get into the rehab aspects of things, but that is certainly an area of tremendous growth and improvement. Another area which we will talk about today a little bit is in the frame of prevention. And prevention has not really been addressed all that much when it comes to maternal fetal medicine, largely because we're dealing with a very complex system. We're dealing with mom and baby, and there's been certainly a hesitancy, I think, to utilize medications or drugs in moms in order to protect the fetus, partly because of some of the negative negative experiences we've had in the past that Peter alluded to a little bit, and the whole concept that we really are dealing with a rapidly developing brain, and we really often don't know what the effects of a medication will have either on the mother or the fetus. The problem is, though, that unless we begin to look at this, we're going to be really avoiding 80 to 90% of the babies who have an intrauterine event, or 80 to 90% of the babies who develop cerebral palsy. So we're going to have to think about that and address it at some point in time, and that's probably going to be very soon. So mild hypothermia we all know about. I'm not going to really spend any time on this because we did spend quite a bit of time on it yesterday, but certainly we can look at some questions later on. There's been some really excellent reviews in the literature in the last several years looking at what medications may be amenable to taking from the so-called bench to the bedside. And traditionally, we've looked at many medications in animal studies, both in the adult world and in the pediatric world. Few of them have gone on to clinical trial with any success, and I'll allude to that a little bit later. But these are, if you're interested, some very good reviews to look at in terms of getting a broad perspective of what's out there right now. So Nicola Robertson and that group did a very nice study or a nice review in JPEDS. The Italian group did as well, and Michael Johnson did a nice review in Lancet Neurology last year. So if you want to have a look at those, that'll be, I think, some good information. This is some work done by Alistair Gunn and his group, and again, this is the JPEDS paper and Nicola Robertson. And they looked at a number of different medications and graded them to determine which ones might be most beneficial to go from bench to bedside in the next couple of years. And on the bottom here, sort of on the X aspect of the table, they graded them according to antenatal usage, and here to postnatal usage, from the left to the right, going from the most likely ones that'll be effective to the least likely ones. And here they've got BH4, melatonin, nitrous oxide inhibitor, xenon, allopurinol, vitamin E, and on down the road. And most of the same drugs here, but in slightly different order. So BH4 here has a low likelihood of being used as a postnatal drug, but a very high potential for being used as an antenatal drug. And I'm going to go through some of the studies very quickly to give you some idea of what's been found in the literature in that regard, and then move on to some other aspects. So this is BH4, and Sid Tan in Oregon did some nice work in his rabbit model utilizing BH4 as an antenatal neuroprotectant. And what BH4 does is it converts tryptophan into nitrous oxide so that it has a neuroprotective effect and enhances vasodilation as well. And what you can see in this group, what he did was he looked at where BH4 was concentrated greatest in the brain, in the various areas of the brain at different ages. And so this is during pregnancy at E22 all the way to P1. And what he found was that it's most concentrated within the thalamus along all of these developmental stages, and particularly at E22, I think that is. No, sorry, E32, which is near the time of birth. And then they looked at injecting it into their rat pups using a model of basically uterine or placental insufficiency, and looked at some behavioral abnormalities or improvements in behavior. And he certainly found that in locomotion, writing response, dystonia or spasticity, and muscle tone, that BH4 improved each of these aspects of their neuromotor response. And if you've seen any work on his animal model, what they do is they put a balloon catheter into the aorta. They inflate it so it decreases the blood flow to the placenta. It creates essentially an ischemic insult for a brief period of time. And the pups, when they're delivered, look very much like they have some spasticity. The difficulty with this animal model is that it's a rabbit pup, and so you can't follow them out too far because they don't survive, and it's very hard to do behavioral testing on a rabbit when they're getting older because they're jumping all over the place. Much like a lamb, I would imagine, would be difficult to do late. That's why everybody loves the rat. Okay, so Pierre Grasson in Paris has certainly taken a liking to melatonin, and he's used this on several occasions, looking at a model where he injects basically a neurotoxin into an area of the brain, causes damage that you can see here, causes a cyst within the white matter and the gray matter, and then is utilizing melatonin intraperitoneally to see if that can be prevented and saved. And what he's found is that when it's injected into the cortex, there's really no particular protective effect of melatonin, but there's certainly a very significant protective effect of melatonin in the white matter, and that translates in different sections, and you can see it here histopathologically, looking at stains for myelin basic protein in the brown here, and it looks like it's fused together, but what has happened here is it's really prevented the damage from occurring in the first place. This is where he's used prenatal or antenatal melatonin. This is a Japanese group that has looked at this in a control animal where you don't see any hippocampal damage, where they've used the 7-day-old rat pup to induce essentially a neonatal stroke, and you see many neurons dying, and where melatonin has been given prior to the onset of the injury, and it essentially prevents it from occurring. These are high-powered microscopic EM magnifications, and here's damage to the mitochondria, and here it's been essentially prevented from occurring. And then when they've looked at evidence for lipid peroxidation, what they find is that there's a huge amount of lipid peroxidation in the side of the injury, and that's once again prevented by the utilization of melatonin. So several medications already that have been utilized in animal studies for sure, that seem to be relatively safe, and they may be effective in antenatal use, and that's probably very important. This is a systematic review done by Susan Jewell and her group in 2009, looking at erythropoietin, which has been very popular in certainly the United States and North America, as something that can be used both alone and as adjunct therapy to hypothermia. And I think some of the studies are showing that it's likely going to fall out of favor. So when they looked at single doses, they really didn't see much of an effect overall. But when they utilized, they looked at studies that utilized multiple doses, there was a significant improvement in overall effect. But when they then looked at a combination of different animal models that erythropoietin was tried in, they actually found quite a bit of variability, and overall it seemed to lose its effect. So in this model, it's a cauterization model where they just occlude the middle cerebral artery using cautery. This is an injection of clot. This is an intramural filament, and then there's a group of studies where they didn't know what was done. But if you look across the board here, it seemed to really lose its effect in the various models, and so lost its efficacy, and which is a bit unfortunate. Here, this is looking at erythropoietin again in various different cell cultures. And the top one, they removed the serum, which is essentially an ischemic type of insult where they do oxygen glucose deprivation. They added erythropoietin and they got improved cell viability. And when they added it along with serum, it was similar. And that's true for each of those. When they looked at what one might assume would be a seizure type of model, because they added canic acid, which is a potent neurotoxin that can either cause cell death or induce seizures. They too found an improvement when they added erythropoietin. And then another group looked at the SVC, or where the cells are being made, and again found an improvement with erythropoietin in terms of cell loss or volume of the SVC following a hypoxic ischemic insult. So a bit of controversy around erythropoietin. It's not clear that it's going to be a medication that's going to move forward as effective either antenatally or postnatally. And certainly based on the preclinical trials, it doesn't look like it's going to move all that much forward with respect to adjunctive therapy for hypothermia. Allopurinol is something that each of you probably knows about and has been in the literature for quite a long period of time. There have been several studies that have looked at it both in humans and certainly in animal studies. And this is a systematic review, again, looking at its effectiveness. Allopurinol versus control or placebo in no drug, and looking at severe outcome of death or severe disability. And you can see here you're getting sort of familiar with these kinds of graphs, that really the overall protective effect was quite negligible. It's leaning to the left a little bit there, but really not significant enough. And similarly, when they looked at seizures during the neonatal period, they also really didn't find any positive effect. Nonetheless, people have been pursuing allopurinol because it has been used clinically and it seems to be safe. And when they look at the total group of children who have, or infants who have had been asphyxiated, they actually found no significant effect overall. But when they subgrouped them into the moderately asphyxiated babies, they actually found at least a trend towards improvement in outcome with a p-value of 0.03. And depending how rigid you might be, then it shows as though there might be an effect. And long term, they actually found a significant effect in those with severe outcome. So somewhat similar to what people have been finding with the hypothermia, in that it's beneficial or may be beneficial in the moderate HIE group, but perhaps not as much in the severely ones when we group the two together. N-acetylcysteine is another medication that has been looked at both in animals and is starting to get some traction in the human data. This is an LPS model where they inject LPS into the intraperitoneally, cause an inflammatory response or a fetal inflammatory response. sometimes in association with a middle cerebral artery occlusion, and that's what occurred here. And you see that in the absence of NAC, you get a huge area of damage in this rat model, which essentially causes a neonatal stroke. And when NAC is added to this before that, or sorry, after the intervention, then you see improvement in the overall outcome. And that's noted just by pathologically here in the various parts of the brain, the cortex, the hippocampus, the thalamus, and the striatum. And then just measuring the infarct area in total, there's a significant improvement utilizing NAC. This is another group who's looked at NAC and LPS and have really found very similar outcomes. In this particular experiment, they looked at the production of interleukins or cytokines or the pro-inflammatory markers, IL-6 and IL-10, and found a reduction in their production using NAC, either before the injury and then following the injury, or just after the injury, and there really wasn't much difference between those two. And these are IL-6 levels within the amniotic fluid as well. So it seems as though NAC has been protective by reducing or by having a profound anti-inflammatory response, and clearly by having a protective effect in the pathologically. This is another one where they didn't use LPS, they used an HIE model or a hypoxic ischemic model, where they essentially caused damage to an entire hemisphere in the dark red there. And then this is the opposite in the light area. Using NAC after the insult, you get a significant improvement in overall outcome and in behavioral outcomes as well. And here, where they looked at it, where they looked at the production of TNF alpha. During the course, they found a marked improvement or decrease in the production of TNF alpha as a marker of free radical production and as a marker of pro-inflammation. So NAC has really been very positive. It's been something that's been in the literature, certainly in the animal literature, for some time, and there have been several attempts to look at clinical trials with it. If you Google, I think it's www.clinicaltrials.gov, you'll find a host of trials that are ongoing. So a number of people have looked at various different aspects of this cycle of events to see if they could interrupt it. Glutamate blockers have been used. Certainly MK801 blockers have been utilized. Anti-inflammatory blockers have been utilized. Blockers of programmed cell death or apoptosis. Free radical scavengers have all been utilized, and many have been effective in animal studies for sure. The trouble is that they haven't been overly effective in translation into clinical trials. And we haven't really looked on the newborn side of things, but this is a relatively older slide at adult clinical trials of strokes and what has happened in terms of whether or not they've been able to be translated into humans. So there, at this point in time, there were over 178 clinical trials for stroke, and recognize that many of the agents that were utilized for stroke in adults were actually attempted to be utilized in newborns as well. We're getting away from that a little bit now, but back then, that's what we were doing. And there were 178 trials, 50 agents. So if any of you know a clinical trials are generally speaking several millions of dollars, usually multi-center in nature. And of all of these, none were positive. None of them turned out to be effective in clinical trials in humans. So there's a missing link occurring between the animal data
and the human data. And I think partially it's because of the kind of animal models we've been utilizing, and partially because we're as I've said before, sort of throwing the baby out with the bathwater, and we tend to overstretch what our findings are. Sorry. So in the newborn, we have to be particularly vigilant in how we're going to translate things that we look at in the animal model into the human. And the reason is that there's a lot of normal brain development going on in the human newborn. So we know that the SVC is a place where cells are migrating out, they're multiplying, they're developing arms and legs that stretch out to each other and do a lot of collateralization and communication between each other. And that's all happening, you know, in the last trimester and the first months and years of life. And that's happening because of certain biochemical interchanges that are occurring that utilize glutamate. And you'll remember that that's the neurotoxin that under these circumstances is helping the development of the brain, but under pathologic circumstances like hypoxia or ischemia or a fetal inflammatory response is highly toxic to the brain. They utilize calcium, also toxic to the brain under aberrant circumstances. A programmed cell death is something that happens naturally, and between 40 and 50% of cells will naturally die. But this increases under circumstances that are not normal. So if we're utilizing medications to try and block these things from causing damage, we have to also recognize that we're blocking aspects of normal developmental function. And so we have to be extremely cautious about how we use those medications. And that's emphasized by a couple studies that I'll show you, and Peter will like the next one. But this is an early study by Catherine Ikonomoto, published in Science in the late 90s, and she looked at our typical P7 rat, which is presumably a near-term rat in terms, or a near-term human or replication of that. She injected 3 doses of MK801, which is a well-known NMDA blocker or glutamate blocker, and sacrificed the animals 24 hours later. So in this top panel here, this is a coronal section of a rat brain stained for apoptotic cell death, and you can see that it's pretty blank. There is no apoptotic cell death that they found. But after she injected the MK801 in a normal brain, this is just a normal brain, it dramatically increased the amount of apoptotic cell death. So this was a message, I think, to most of the scientific community that you can't just sort of take drugs that we think are going to protect the brain and give them to a newborn animal, or certainly not to a human, and expect it to be benign in nature. We did some work on caffeine and actually morphine in our own lab, and looked at, and we injected amounts of caffeine alone, or morphine alone, or in combination that would be equivalent to what we use in apnea of prematurity. These are normal rats. They're not harmed in any way. So this is a control brain. There's no injury. This is under circumstances of caffeine, and these bright green dots are cell death, and this is the thalamus here that we're looking at. When we injected morphine, actually, it didn't seem to cause much damage, and the combination of the two was essentially the same as caffeine and morphine. And when we measured it in various areas of the brain, what we found was that caffeine did seem to enhance cell death alone, and we've now gone on to do And we looked at 2 different time frames, 12 hours and 24 hours, and it essentially was the same. And we did find that caffeine injection caused an increased amount of cell death under normal circumstances, under circumstances where the brain was otherwise normal. So we felt that, that kind of information, along with others that have shown that dilantin causes the same thing and ketamine causes the same thing, and a few of the other anticonvulsants that we use, that we need to be extremely careful and vigilant. And the problem we have is that babies get injured when we can't see what's happening. So the vast majority of them actually get injured in utero, not at the time of birth, and not as much necessarily after birth. It can occur anytime during gestation, and I've emphasized that a number of times. And the things that we're trying to do that have the potential to help, or we think might help, may also have the potential to hurt. So we have to rethink how we're doing things. And we have to find a balance of therapeutic interventions between what is normal development and what is neurotoxicity. So we went on to develop an animal model that we felt was better reflective of what's happening in utero, and looked at a model that would cause injury by placental insufficiency. And this is where I kind of have a little bit of fun, and others have looked at this as well. So people have started to look at natural health products, and this is supposed to replicate that. So there are several studies that have looked at resveratrol, which is it's a synthetic product, but it's synthesized from a natural health product from grapes. They use our typical Vannucci model, where we ligate the artery off. This is not my work, but ligate the artery, cause a big hole in the brain. And when they injected resveratrol, it essentially prevented that from occurring and rescued that from occurring. This is the corpus callosum under injury circumstances, and following the use of resveratrol, it virtually eliminated that injury. And this is work using a water maze to assess memory, and rope suspension to assess strength. And again, the utilization of resveratrol really was very helpful in eliminating the damage, and not only the damage, but the behavioral outcome of that damage. People have looked at pomegranate juice, believe it or not. This is work by David Holtzman in the United States, and he used various doses: high dose, mild dose, a low dose. Also in that Vannucci model, where they ligated the common carotid artery, and what they found was a dose-related improvement in the overall area of damage and in the amount of free radical species that were produced as a result of that damage. And then there's several studies by a Chinese group that has looked at grapeseed extract, and in fact the grape producers of California will give you a grant if you want to look at grape seeds, either in the form of grape seeds itself or resveratrol, which is a synthetic aspect of that, to determine whether or not it can be used for much more than just eating. And here they looked again at our typical model of the Vannucci model, and it improved overall outcome in a somewhat dose-related fashion. The production of glutathione was improved with the grapeseed extract. This is a microscopic brain score pathologically, and they looked behaviorally at the number of foot faults, and also found them to be improved. So we have some good evidence to suggest that we can prevent these things, and what we did in our lab and have been looking at for the last several years is natural health products as well. And we've chosen broccoli sprouts, and I'll tell you why in a minute. So you can get these, so I don't know if you can get them here, but we can get them at our grocery stores. in Canada and the United States. So why broccoli? And not just broccoli, but broccoli sprouts, the young sprouts. Broccoli sprouts is actually one of the most potent antioxidants on the planet. Right now, they're known as phase 2 enzyme inducers, and there's quite a number of natural health products that have a similar outcome. Kale is one, the number of the flavonoids, blackberries, blueberries, all of those things can act as phase 2 enzyme inducers. And phase 2 enzyme inducers basically enhance the body's ability to produce endogenous free radical scavengers. So it markedly increases glutathione, peroxidase, and glutathione reductase by enhancing their production endogenously. And that's important in the fetus because the fetus actually has significantly lower quantities of free radical scavengers than the adult counterpart, and is really unprepared to fight off a free radical attack. So they're great when it comes to physiology and development, but when it comes to pathologic circumstances, the fetus is really unprepared to withstand that. Broccoli sprouts themselves have between about 50 and 100 times the amount of phase 2 enzyme activity that mature broccoli does. So when you're eating a mature broccoli, that's also good and healthy, and do that. But broccoli sprouts has between 50 and 100 times the antioxidant potency. And even amongst all the natural health products and the fruits and flavonoids that I talked about, it has the greatest potency of all of them. So a lot of this work actually started in the cancer field, and people have done some early clinical trials using broccoli sprouts in the prevention of cancer and the treatment of cancer. And a colleague of mine in Saskatchewan, when I was there, started to look at broccoli sprouts in a model of the spontaneously hypertensive rat. So if anybody knows anything about the spontaneously hypertensive rat, it's basically a rat that's been genetically altered so that it develops hypertension as it gets a bit older, and its offspring does, and its offspring does, and its offspring does. And so what we did was we fed this spontaneously hypertensive rat broccoli sprouts. And what we found was that these animals no longer developed hypertension as they got older. And the reason was, as far as we know, was we looked at their arteries, and you can see this is in the normal spontaneously hypertensive rat. There's a lot of inflammatory cells and thickening of the arterial area, and after broccoli sprout usage, this was significantly decreased. And when we measured free radicals, that was markedly reduced as well. The interesting thing is that when we looked at the fetuses, or when my colleague looked at the fetuses of these rats, they no longer developed spontaneous hypertension either. So in other words, feeding the dam, the pregnant mother, prevented her from getting spontaneous hypertension, but it also prevented the fetus from getting it. So we developed a model that we thought was more reflective of intrauterine damage than the 7-day-old rat model that I've been talking about, and we developed a model of basically a fetal growth restriction. And we did that because it really increases the risk of cerebral palsy by about 40-fold, depending on what paper you look at. It's common in live births. It has a high rate of developmental disability, and it's often due to uteroplacental insufficiency. Our model, we did a bilateral uterine artery ligation at around just before 3 days before delivery, and this is kind of what we found. This is normal. Rats tend to have lots of babies in their uterine horn, but when we tie off the uterine horn, they're a lot smaller. and they're growth restricted. And they're growth restricted under these circumstances within the parameters of what we expect, what our definition is for growth restriction in humans as well. And they maintain that growth restriction until at least 3 weeks of age, though there's some catch-up afterwards. And this is a little growth-restricted rat pup compared to a normal rat pup at about P7 here, and this is them at about P21. And then what we tried to look at was, well, what kind of growth restriction were we looking at? So their head circumference is diminished, but when we looked at the so-called cephalization index, what we found is that they're asymmetrically growth restricted. In other words, there's some preservation of brain growth, which is an asymmetrical growth restriction. And then we did a whole bunch of behavioral tests, which would be similar in the rat to human or early developmental reflexes. And what we found was that in the IUGR animals, all of the behaviors were abnormal in the growth-restricted group. But importantly, so we had a very good model of early developmental delay and a very good model, obviously, of growth restriction. And then when we fed these dams, when we looked at them after feeding the dam broccoli sprouts for a week prior to the time that they gave birth, that many of the developmental reflexes, though not all of them, were improved. In other words, or their delay was actually prevented. So we can see here, this is just a sampling of developmental reflexes. So in the growth-restricted group, there was a delay in the forelimb grasp, in hind limb placing, in cliff aversion. And when we fed them the broccoli sprouts prior to the onset of the injury, that prevented their developmental delay from occurring and was essentially the same as normal or sham groups of animals. And that's true for some early developmental reflexes, and it also was true for later developmental reflexes where we looked at ambulation and head lifts, and they're virtually identical. When we looked sort of pathologically at these animals, this is again looking at fluorojade, which is just a marker of cell death. Sham animals, the animals that received the injury or the bilateral uterine artery ligation model and fetal growth restriction. And when we fed them broccoli sprouts, we eliminated or prevented any of that cell death from occurring. So then we wanted to go on and see if this was a good model for cerebral palsy, and in fact it is. When we look at the corpus callosum, which is that thick band of white matter that is representative usually of white matter injury, what we find is that there's a loss in thickness of that of the corpus callosum, and that's prevented from occurring when we feed them broccoli sprouts, both anteriorly in the corpus and in the cingulum peak. When we look at the inflammatory response, looking at astrogliosis, which is just a marker for inflammation, we find that it's slightly increased in the IUGR animals and prevented in the broccoli sprout animals. And here's most importantly what we found when we stained for myelin basic protein. In the sham animals, we have a nice staining for the corpus callosum in the brown here. This is the ventricle. This is the brain or the cortex over here. This is the band of white matter. When we induce the injury with bilateral uterine artery ligation, we essentially lose all of that white matter. And when we fed the animals broccoli sprouts beforehand, we prevented that from occurring pretty dramatically, actually. And then when we measured it more specifically or more objectively, measuring the ventricular size, the very same thing happened. Large ventricles or loss of tissue in the IUGR model, and a prevention of that when they were fed broccoli, and similarly when we looked at the thickness of the white matter staining. We also looked at sort of hippocampal cell counts, because this would be an indication of cognitive impairment. And again, a huge loss of cell number in the hippocampus, prevented by broccoli sprouts, both in the CA1 region and in the CA3 region. And you can see that photographically here. This is a normal CA1. This is a sham. In the IUGR, we lost a host of cells within the model depicted along here, and that was essentially prevented with the IUGR and broccoli. We've expanded that to an LPS model, so we now inject our animals with LPS, and we find that it too gives us an IUGR, or a growth-restricted model, and that's actually prevented with the use of broccoli sprouts. And similarly, we see an improvement in developmental abnormalities, or an impairment with the LPS, and an improvement with the use of broccoli sprouts. And when we measured the number of oligodendroglia, this didn't quite reach significance, but there's a trend towards depletion of oligodendrocytes in the LPS model, and repletion of them when we give them broccoli sprouts. So we're of the mind that natural health products and some of the work that's going on now in the antenatal use of some of the medications will have a huge effect on the vast majority of injuries that will occur to a newborn. And of course, I can't really speak to protection or prevention without at least mentioning stem cells to some extent, because that's a hot topic in the literature. So stem cells, as you know, this is just a review that was done, are cells that are, they originate in a host of different fashions. They're either injected directly into the brain or systemically into the system and find their way to the brain. Many individuals have looked at stem cells in models of brain injury. This is a group by Stephen Ashwell and Evan Snyder, who have looked at the migration of stem cells after being injected into the ventricle, and to see whether or not it goes to the site of injury. So this is a very nice three-dimensional cartoon of MRI scans that they did. The pink is the injection of cells in an otherwise normal rat pup into the ventricle, and you can see it doesn't really move anywhere. This is after injury with the middle cerebral artery ligation. The yellow area is the area of infarct or damage. The pink underneath that is the stem cells, and what they showed here was that the stem cells actually migrated into the area of the injury. We've been looking at, together with some colleagues in Toronto, we've been looking at a shiver mouse model as a depiction of demyelination. A shiver mouse is genetically devoid of white matter, and so they're called shiver mouse because they shiver in the absence of white matter. And what we've done is inject stem cells into the ventricle of the shiver mice at various ages. What we found is that the stem cells differentiate into oligodendroglia and actually migrate throughout the corpus callosum. You can see here, this looks like actually a nice streak depiction, but the green is a fluorescence dye for oligodendroglia, and they're migrating along the corpus callosum where the white matter is actually deficient, presumably to regenerate the white matter. We've looked at some physiologic tests where we're determining whether or not the stem cells that have migrated into the corpus callosum and white matter are actually functional. In other words, do they allow for electrical conductivity? And this is just a fancy way of saying, yes, they do. We can see markers and aspects of improved electrical conductivity from the control animals to those that were injected with stem cells. So nowadays there are a host of clinical trials actually being done using stem cells, most of which, or some of which, are autologous, some of which are allogenic, and most are looking at chronic injuries, though a few are looking at acute injuries. And these are occurring both in the States, Mexico, and some in China. The ones that I know of outside of the States are not really sanctioned studies. They're paid for privately by the individuals. The one from Duke University is a sanctioned study and looking at early acute involvement with stem cells. So there really are a host of things that are going on in the neuroprotective world, some of which stem cells are actively ongoing, although I have to say that most individuals in my world are not overly confident that it'll make a huge difference, but it's very, the public is very keen on seeing this being done. And so there is a sanctioned study out of Duke University. We're investigating it, at least in the animal models as well. There are probably 2 or 3, if not more, newer medications, including melatonin, BH4, that will probably go to clinical trial in the next several years. And for those of us, we'll be looking at, I think, preventive therapy with natural health products, including things like resveratrol, sulforaphane, which is the active metabolite in grapes, in broccoli sprouts, and possibly pomegranate as well. So it's a little bit different than what they're looking at in the stroke world in adult and in ischemia, and I think a bit different than what people have been thinking of in the past, largely because we probably can't take medications that are going to interfere with normal physiologic standards and try and make it work in a mother and fetus. So I'll just end there and ask for questions if there are any. Thank you. Any questions at all? Yeah. Are there any? To determine whether or not a fetus has had injury? There are actually a lot, but I'm not sure that many are being utilized clinically as sort of standard of care. I know some centers are using cytokines like IL-6. There are some centers that are using lactate as a marker of injury. Obviously, many centers are using MRI abnormalities early on after birth. But there are not very many centers that can determine those are injuries that would happen around the time of birth, like a perinatal asphyxial injury. And I think because we're recognizing that that's a relatively small percentage of the kids who ultimately develop cerebral palsy or developmental delay, people are trying to look more at it in uterine injuries. The obstetricians have some markers that can determine fetuses at risk. They do fetal Doppler studies that look at placental flow and can determine to some extent which fetuses are at risk for growth restriction, which increases their risk for hypoxia. But beyond that, there's not many things that are being used routinely. I think that's an area of huge investigation right now because, as you point out, it's really important to try and figure out who might be at risk before we think about who to treat. The good aspect, even though it's a bit out there about natural health products, is the presumption is that it may be able to be used prophylactically, much like folate is as a prophylactic supplement to pregnant mothers for spina bifida. And that's sort of the underlying hope, I suppose.
You've mentioned a lot of way of prevention of perinatal asphyxia. What about magnesium sulfate in prevention?
In what way? Prior to birth, you mean? So again, I'm not, aside from it being used in those patients who have preeclampsia, I'm not aware of it being utilized in any trials in the absence of any injury, or in the absence of any. Are you aware of some? Certainly, it has been shown to be effective in mothers who, or in infants of mothers who have had preeclampsia, and there are some clinical trials, but I'm not aware of any outcomes yet.
No, there's three or four randomised trials, large trials, including one from Australia, that have looked at prophylactic magnesium sulfate to mothers threatening to deliver, and the 2-year outcomes are now out, and there seems to be a significant reduction in cerebral palsy in babies that have had the antenatal magnesium sulfate. So this is, again, it's not a silver bullet, but it does reduce morbidity and should be being used more widely.
Yeah, but none. I'm not aware of any in like normal pregnancies. Is that right? It's targeted therapy. Yeah. Are there any other questions? Good.